Thank you for the organizing committee to allow me to present this perspective. We should peel epiretinal membranes with good visual acuity pro. I have a Dutch ophthalmic consultant agreement, and I am talking about vitreoretinal surgery. That might be a bias. Patients want excellent vision. How do I know that? I want excellent vision. And patients pay thousands of dollars for their cataract surgery out of pocket for premium intraocular lenses and astigmatism management when it makes very little difference in their final visual acuity outcome. Gary Brown has taught us that even patients with best visual acuities of 20/40 in their better eye would be willing to give up 20% of the remaining lifespan to have 20/20 vision for whatever life they would have left. If the visual acuity was 20/70, people would be willing to give up more than a quarter of their remaining lifespan to see 20/20. Patients value good vision. Advising patients to let visual acuity deteriorate is bad medicine, even if the fellow eye has excellent vision, because sometimes the worst seeing eye becomes the better seeing eye because of something bad happening. We've all seen this in our practices. Retina surgeons must strive for best visual acuity in the management of eye disease in each eye, including those with epiretinal membranes. Achieving excellent final visual acuity and function in epiretinal membrane surgery requires earlier intervention. Epiretinal membranes are a progressive disease. In the Blue Mountain Eye Study, 28% of epiretinal membranes had progression by 5 years. And the course may be variable, and there may be years of inactivity, and it's very unpredictable when the vision starts deteriorating, but they do deteriorate in time. Now, a reason not to do surgery might be when the visual acuity is excellent and there's no metamorphopsia and there's normal binocular function, or perhaps when there's a strong desire not to have surgery. Oh, what just happened? Improvement is limited following epiretinal membrane surgery. That's why early intervention is important. Only 2/3 to 3/4 of patients or eyes have improvement following surgery, and the mean improvement in most studies is only about 2 lines of visual acuity. There are some predictors of poor visual acuity outcomes: poor preoperative visual acuity, cystoid macular edema, ectopic foveal inner layers, small foveal vascular zone on OCTA, or disorganized inner retinal layers, ellipsoid layer disruption, and prolonged P1 time and multifocal ERG. But we shouldn't wait till there's bad visual acuity. The predictors of good visual acuity outcomes in epiretinal membrane surgery is better preoperative visual acuity and shorter duration of symptoms, and of course the absence of all the aforementioned characteristics. So Harry, with all respect, I think you're one of the people I admire most in our field for a long time, but you've been around for a long time. And perhaps you're scarred from the early days of vitrectomy surgery when we had when there were rampant complications in the 70s and 80s. And I think you carry a lot of baggage from those days. I think it's time to kick the baggage and realize eyes do well after vitrectomy. Retinal detachment risk is now quite low, less than 1%, closer to 0.5% if you look at the recent studies. Not 5 to 10% like in the 1970s and 80s. Endophthalmitis risk is less than 1 in 2,000. Vision recovery is quicker, pain is minimal. Compare that to the endophthalmitis risk of cataract surgery, which is twice or more compared to vitrectomy, as you would know better than anybody. And yet cataract surgery is done routinely in eyes with 20/20 and 20/25 visual acuity because of the disabling symptoms of glare and starburst and other things. Why are retina surgeons holding back and letting vision deteriorate and not saving it? I propose that epiretinal membrane peeling must be done before vision deteriorates. Perhaps the optimal indications might be 20/30 visual acuity, because we do get an average of 2 lines visual improvement, any metamorphopsia, and any loss of binocularity. Thank you. And if you don't want to take care of your patients, you can send them to me.